Hello, I'm Eric Parnas. I'm an assistant professor of medicine at Harvard Medical School and a hematologist at Brigham and Women's Hospital. Today, I will be covering a board review in hematology. Here are my disclosures. The first question is a 35-year-old woman coming to the emergency room complaining of exertional dyspnea over several days. She has no past medical history, takes no medications. Her exam is remarkable for a few small ecchymoses, mild scleral icterus, and a soft hollow systolic murmur. Here are her lab studies, notable for significant anemia with a hematocrit of 23% and low platelets at 36. Her coags are normal, fibrinogen slightly elevated at 450. Her kidney function is normal, and the LDH is quite high at 1,535. The peripheral blood smear shows schistocytes. And the question is, which of the following is the appropriate next step? A, send serum toxicology panel and stool studies for E. coli. B, initiate therapeutic plasma exchange as soon as possible. C, observe for now, and then initiate plasma exchange if the platelets fall below 20. And D, observe for now, initiate plasma exchange if the patient becomes febrile or the creatinine rises. So the key to this question is to find combinations that trigger possible diagnoses and then treatment plans. And in this situation, we have thrombocytopenia with anemia and schistocytes on a smear. The schistocytes being the hallmark for microangiopathic hemolytic anemia. Therefore, the right answer would be to start plasma exchange as soon as possible, recognizing that this patient possibly has TTP. Here's an example smear of schistocytes, the fragments of red blood cells. TTP often has a, we talk about a pentad of features, the pentad being microangiopathic hemolytic anemia with schistocytes, thrombocytopenia, fever, neurologic symptoms, and kidney failure, kidney disease. But it is unusual for all five of these features to appear in a case of TTP. What we absolutely need are the first two, the schistocytes and the thrombocytopenia. All others may or may not be there. The pathophysiology of TTP comes down to a protease called ADAMTS13, which is responsible for breaking down large multimers of von Willebrand factor. Without ADAMTS13, these multimers continue to grow, expand, multiply, and then form blood clots in different organs. TTP is a dangerous disease. It's one of benign hematology's few emergencies. Most patients, maybe 90% of patients, would succumb to the disease without any kind of treatment. Fortunately, plasma exchange works well, and with plasma exchange, 90% of patients will improve. Relapses are still common at about 30%, and when relapses do occur, we move on to other treatments in addition to plasmapheresis, such as rituximab or the new caplacizumab, which blocks the binding of von Willebrand factor to platelets. The next question, a 54-year-old man of Greek ancestry is seen 3 days after completing treatment for an upper respiratory tract infection with trimethoprim sulfamethoxazole, also known as Bactrim. On review of his history, it seems that he started to get better, but now is becoming more short of breath and fatigued. And his labs show a hematocrit of 28% with a reticulocyte count of 11%. MCV is also elevated at 101. The most appropriate course of action at this time is A, obtain folate and B12 levels, B, observation return visit in a few weeks, C, test for G6PD deficiency, or D, do a bone marrow biopsy. What are the key clinical data provided here? Well, we see that the patient has significant anemia with a reticulocytosis, and the added information of a recent course of antibiotics and his Greek ancestry are relevant here. The answer is to test for G6PD deficiency, recognizing that this patient may be hemolyzing with a reticulocytosis. When we see an elevated reticulocyte count, we think of two things. One is either recent bleeding, and that is not really chronic bleeding that depletes iron stores, because once iron deficient, patients have a difficult time mounting a reticulocytosis. And the other possibility is hemolysis. So when I see an elevated retic count, I start working up the possibility of bleeding and hemolysis. And with hemolysis, we like to test standard labs like the CBC, reticulocyte count, LDH, haptoglobin, bilirubins. And then we start thinking of the different possibilities, the different causes of hemolysis. So could this be autoimmune, in which we would test a direct Coombs? Could this be G6PD deficiency? We would want to test a G6PD level. Well, there are two main subtypes of G6PD deficiency. The A negative isoform, which is commonly seen in people with African ancestry, tends to be more mild than the other isoform, the Mediterranean type, which tends to be more severe. G6PD is at a higher level in red blood cells that are young, and then over time it disappears. And so when an acute hemolytic episode happens, the G6PD levels often start to normalize as the red cell population that remains is younger, the retics. And so it can be difficult to diagnose this disease during an acute flare if the older red blood cells without G6PD have hemolyzed, leaving only younger red cells with G6PD. In that situation, we need to get a Heinz body preparation of a blood smear to see if there are Heinz bodies present. This is a smear showing the Heinz bodies, which are hemoglobin precipitates. And those precipitates change the deformability of a red blood cell, which is normally very squishy, so it can maneuver through small capillaries. And when the hemoglobin precipitates, the red cells become more rigid and start to lyse. A Heinz body prep does require a special stain, so it's not seen on a routine blood smear, but has to be ordered separately. There are many different medications that can cause a hemolytic episode from G6PD deficiency, particularly medications. Classic ones being sulfa drugs, like the Bactrim in this case. Dapsone is another common one, and favabines are our classic food item that can do it too. The treatment is mostly supportive with red blood cell transfusions as needed. I think it is important to point out that methylene blue is a trigger for G6PD hemolysis, not a treatment. We do use methylene blue for treatment of methemoglobinemia. That's something different. So what is happening in G6PD deficient patients is that there is oxidative stress with certain exposures, such as those fava beans, and without G6PD here, we get a depletion of NADPH and then an increase in hydrogen peroxide and free radicals, which start to damage hemoglobin and cause its precipitation. The next question is a 35-year-old woman from the Dominican Republic coming to clinic for her first visit. No medical history. She has 2 children. After the birth of her second child 3 years ago, she was told to take iron tablets twice a day. And aside from oral contraceptive, that's her only medication. Her labs show a white count of 4.6, hematocrit 35%, MCV quite low, 66, platelets 256, iron is 150, TIBC 275. We don't have a ferritin here. The most appropriate next steps are A, phlebotomy for hemochromatosis, B, continue current iron therapy, initiate workup for chronic inflammatory process, C, switch the therapy from oral iron to IV iron, D, discontinue iron therapy, send a ferritin and a hemoglobin electrophoresis. The key laboratory studies here are the very mild anemia. I mean, that hematocrit of 35% is essentially normal, and yet the MCV is profoundly low, while the iron studies of what we have are in the normal range. This combination suggests that this person does not have iron deficiency, but has a hemoglobinopathy. The reason for that is that in hemoglobinopathies, the size of the red cell becomes very small, disproportionately to a degree of anemia. Whereas in iron deficiency, patients will become very anemic as the MCV falls. So what we want to do is try to confirm that this person has a hemoglobinopathy. And given their very mild anemia, they're probably just a carrier having a thalassemia trait instead of a thal major or a thal intermedia. And it would be important also to complete the iron studies with a ferritin, so we know that what the iron storage is doing. This person has been on iron therapy for some time unnecessarily, and it may have at this point iron overload, which is a common problem in hemoglobinopathies. Iron overload in hemoglobinopathies happens for several reasons. One is often they need regular blood transfusions. That's a big iron overload. Sometimes they mistakenly take iron tablets, as in this case. And the third is iron overload can occur within the ineffective erythropoiesis that we see in thalassemia. Here is a blood smear of somebody with thalassemia. We see a lymphocyte down at the bottom as a comparator for the size of the red cell. In thalassemia, red cells should be small and hypochromic. This slide is really capturing the hypochromia as the central pallor has expanded in all of these cells. But also target cells are common in all hemoglobinopathies. Here's an example of a target cell where we have a darkened center. The next question is a 74-year-old man with diabetes who comes for routine follow-up. He also has hypertension, takes an ACE inhibitor, has BPH, and on review of your records, you see that his hematocrit has been slowly declining over the last 3 years, and it's now quite significant at 28%, with an MCV of 84, platelets 340, the creatinine 1.9, LDH is 230. What is the most likely etiology of this anemia? A, combined iron and B12 deficiency. B, medication effect from the ACE inhibitor. C, EPO deficiency. D, anemia due to marrow replacement from prostate cancer. So here we recognize that this person has anemia with an elevated creatinine. And those two items together should trigger the thought of two types of two causes of anemia. One is multiple myeloma. So checking an SPEP is always a good idea when people have anemia with kidney disease. And the other is simply anemia of chronic kidney disease resulting in EPO deficiency, which is the answer here, the best answer. So when the kidneys sense lower oxygen levels or anemia, then the kidneys start making erythropoietin, which then stimulates bone marrow to make red blood cells. And when the kidneys don't work, they don't make enough EPO. And it turns out that people with diabetes are much more sensitive to this problem and tend to have a more significant EPO deficiency than others. It is crucial to recognize that the normal EPO level, the normal EPO range, is not normal for anemic patients. So the more anemic someone is, the higher their EPO level becomes. It is a common mistake to see an EPO level in the normal range and assume that they are not EPO deficient when that's not the case. Somebody with a hemoglobin of 10 will typically have an EPO level around 100, which is really high. So if they're not getting up there, that is an EPO deficiency, even if their EPO level is above the normal range. The next question is a 23-year-old man with sickle cell anemia admitted for pneumonia. He had a dry cough, fever to 101, and was found to have a right lower lobe infiltrate on chest x-ray. Oxygen saturation was 94% on room air. He was not feeling short of breath and placed on antibiotics, cefuroxime, with IV hydration, and given a red cell transfusion as well. On admission, the hematocrit was 21%, white cells 18, platelets normal. A day later, he began complaining of increased shortness of breath and was found to have an oxygen saturation of 86%. The chest x-ray was repeated, showing bilateral lower lobe infiltrates. In addition to supplemental oxygen, what's the next step? A, obtain a VQ scan. B, administer furosemide. C, transfuse red cells. D, add coverage for atypical organisms and transfuse red cells. E, add coverage for atypical organisms and perform an exchange transfusion. I think this question is challenging because all of the answers are pretty good, but there is one that is better than the others. So one has to recognize, in order to answer this question, the features of acute chest syndrome, which require pulmonary infiltrates plus some sort of symptom, whether it's fever or chest pain, shortness of breath, etc. But we often don't complete the proper treatment for acute chest syndrome until hypoxia becomes a real problem. It is also important to recognize that acute chest syndrome is often caused by atypical infections, such as mycoplasma or chlamydia, and covering for atypical infections is essential. So adding in something like azithromycin or doxycycline would be important here. The red blood cell exchange is the gold standard for treating acute chest syndrome. The idea here is that we are removing the sickled cells and thus removing the mechanism to occlude small blood vessels and replacing it with normal red blood cells that won't sickle. And then that will improve oxygenation. We exchange transfuse for acute chest syndrome and also stroke and priapism. The next question is a 76-year-old woman on warfarin for atrial fibrillation, normally anticoagulated to an INR of 2.5, but was found to have an INR of 5.8 with routine testing. She's not bleeding. She's asymptomatic. What is the next step? Decrease the dose of warfarin by 50%, or B, hold warfarin and give vitamin K 1 milligram subcutaneously. Hold warfarin, administer 2.5 milligrams of oral vitamin K. D, hold warfarin, recheck the INR in 1 to 2 days prior to restarting therapy. And E, hold warfarin for 1 day, restart at 50% of previous dose the next day. So the right answer here is D, holding the warfarin and rechecking INR in 1 to 2 days. This is, I think, a difficult question as well, because all of the answers are pretty good, maybe with the exception of B, since we don't do subcutaneous vitamin K. We can give it IV, we can give it orally, you can give it intramuscularly, but subcutaneous is not really a thing. There are, I'll just say that there are guidelines by the American College of Chest Physicians outlining exactly how to manage elevated INRs from warfarin. And one of the key thresholds is an INR of 5. Below 5, it's fine to modify the dose without taking a pause. But an INR above 5, typically we should be holding warfarin and readjusting once the INR is better. The way warfarin works is that it stops vitamin K dependent factor production in the liver. So warfarin essentially is an anti-vitamin K. The vitamin K dependent clotting factors are 2, 7, 9, and 10. Those are 4 that are really important to remember as the vitamin K dependent factors. And it even affects our treatment decisions later on when we think about replacing specifically those factors. The half-life is long at 40 hours. And so the effects of warfarin, as anybody who has used it can attest to, it lasts a long time. And that's why when somebody is bleeding on warfarin or needing urgent surgery, we have to reverse it. So vitamin K, as I mentioned, can be given orally or intravenously. The intravenous probably is faster, and they're all safe. They're all safe and effective. We now are able to replace the missing clotting factors 2, 7, 9, and 10 in a complex concentrate called prothrombin complex concentrate. In the US, the brand name is called Kcentra, and the doses depending on the INR. So the higher the INR, or the more we have to reverse, the higher the dose of this 4-factor PCC we'll use. Vitamin K should be given at the same time because we are still looking for a mechanism to block the warfarin effect. We have 4 main DOACs available. DOACs being the direct oral anticoagulants, also called the new oral anticoagulants, although they're not so new anymore. Dabigatran was the first one. This is an antithrombin medication, whereas the others are anti-10A, rivaroxaban, apixaban, and edoxaban. It's important to know how to reverse these since the bleeding emergencies happen. FFP typically won't have enough factor to help, but a 4-factor PCC, which includes factors 2, 7, 9, and 10, will. So it does have 2, it does have 10. 7A or Novo7 may also help, but we now have drug-specific reversing agents available. Idarucizumab is anti-dabigatran, and Dexanet blocks the 10A inhibitors, rivaroxaban, apixaban, and edoxaban. The next question is, a 24-year-old Caucasian female found to have a right popliteal DVT while on birth control. Of the following inherited conditions, which is the most likely? Antithrombin 3 deficiency, protein C deficiency, homocystinemia, factor V Leiden, or prothrombin gene mutation? And the answer is factor V Leiden, simply recognizing which of these is the most common inherited thrombophilia. Factor V Leiden is seen in 4 to 6% of the Caucasian population, particularly from Northern Europe, but it can be seen in people of all diverse ancestries. Prothrombin gene mutation is less common, but still 2 to 3% of Caucasians. And then the others are very rare. It's at the last bullet, elevated factor levels, factor 8, 9, 11. These are somewhat controversial because their increased risk of causing blood clots is so small. I usually don't include it in my thrombophilia workup. The common question is, when do I test for these? Because we now recognize that it's not cost effective to test these in all patients with blood clots or all patients at risk for blood clots. But and maybe, and there is debate about whether or not it's cost effective to test it at all. But there are situations when we do consider it. Most importantly, will it change our management? Will it extend the duration of our anticoagulation plan? Or possibly will we start somebody on anticoagulation because they have a thrombophilia? That thrombophilia has to be really severe for somebody to be started on a blood thinner without actually having a blood clot. That almost never happens. But if the clot is happening in somebody with a family history or a recurrence of clots in a young age, perhaps during pregnancy or on birth control, we would consider testing these. Next question, which of the following statements is true regarding oral replacement with B12? A, it is only effective in patients who possess intrinsic factor. B, since it costs more than parenteral replacement, it should be discouraged. C, it is generally effective, though requires monitoring for compliance. D, when used in appropriate situations, the dose and frequency are similar to parenteral B12. And E, methylmalonic acid and homocysteine levels cannot be used for the monitoring of therapy. And the answer is C. It is generally effective, though requires monitoring for compliance. So the diagnosis is somewhat challenging because the tests aren't very good. Clearly, when somebody's B12 is less than 200, they are B12 deficient, but you can have B12 levels in the normal range and still be B12 deficient. Homocysteine and methylmalonic acid are helpful. They both have a tendency to increase in B12 deficiency, unlike folate deficiency, where it's only homocysteine, not methylmalonic acid, that goes up. And then what happens when somebody has a B12 deficiency? Well, this is megaloblastic anemia, and if severe enough, besides being macrocytic and anemic, they can become pancytopenic. With B12 deficiency, neurologic symptoms are common, with peripheral neuropathies from subacute combined degeneration of the dorsal column. And when severe, it can be a cause of dementia. Neurologic symptoms don't really happen with folate deficiency, although we do see core development issues in the fetus when folate deficient. So with B12 deficiency, it is true that intrinsic factor helps absorb B12 at the distal ileum, although it's not an essential part. So even without intrinsic factor, whether that's because of a gastric surgery or pernicious anemia, which is autoimmune blockage of B12, often through an intrinsic factor antibody, it's possible to absorb through the GI tract enough B12 through oral replacement. Not always, but sometimes. So there are other causes. Dietary deficiency is extremely rare. I would be very cautious about chalking it up to dietary deficiency. In the end, the cause often doesn't really matter. We may not even be able to find a cause many times, but the replacement is still the same. I will use parenteral B12 therapy with an intensive loading regimen when it's severe, followed by maintenance, which is 1,000 milligrams each month. And if it's not severe B12 deficiency, we'll try oral. And even sometimes when it is severe, after a course of parenteral replacement, we can try to convert to oral replacement as well. Again, for folate deficiency, we don't typically see neurologic symptoms. That's a big difference in terms of clinical manifestations, but folate deficiency does cause megaloblastic anemia with some pancytopenia. The next question is, an asymptomatic 35-year-old woman with the following CBC, a white count of 6.2, hematocrit 36, and platelets elevated at 758. Which of the following statements is true? A, therapy with hydroxyurea is indicated. B, warfarin therapy is indicated to prevent clots. C, the possibility of iron deficiency and inflammatory state, or CML, should be investigated. And D, the patient has a very high risk of thrombosis or hemorrhage during the next 5 years. The answer is C. Turns out that iron deficiency can cause a reactive thrombocytosis, so should always be tested for when platelets are elevated. When we think about high platelets, we wonder, is this a reactive cause or a bone marrow disease? And bone marrow disease is when you have excessive growth of something, is a myeloproliferation. And the myelodysplasia myelodysplastic syndrome usually results in low blood counts, not elevated blood counts, but the exception is 5q minus syndrome, which we see in about a third of cases of myelodysplastic syndrome. MDS causes low blood counts and elevated platelets. This 5q minus syndrome is probably more of an MDS myeloproliferative disorder overlap syndrome. When we look at a blood smear, when platelets are elevated, we'll see lots of platelets, of course. You can see that at the bottom where we have these giant clumps of platelets. When I see this many platelets, I really don't start thinking that this is not going to be a reactive thrombocytosis, but more of a myeloproliferative disease, because that's a lot of platelets there. CML, we think about it raising white blood cells and causing a left shift in that distribution. So we see immature forms from neutrophils to bands, metamyelocytes, myelocytes, promyelocytes, et cetera. So this slide is showing, neutrophils and bands and other younger cells that shouldn't be in peripheral blood. But CML also can increase platelets. And we often do see in myeloproliferative diseases basophilia and some eosinophilia. The causes of essential thrombocythemia are mostly known. About half of the cases are caused by a JAK2 mutation, which is the cause of virtually all cases of polycythemia vera. But also a third of cases of ET are caused by a mutation in calreticulin, CalR, and MPL. MPL is the TPO receptor, the thrombopoietin receptor, which causes about 5% of cases. So we now can test these three and be able to diagnose almost all of the cases of essential thrombocythemia. When somebody is low risk for having a blood clot, they don't need cytoreductive therapy. So the risk factors for having a blood clot typically are a younger age, an age less than 60, and a history of having blood clots. Most patients we put on a low-dose aspirin in order to prevent blood clots at any age. The next question, a 67-year-old man with a history of unstable angina is admitted for chest pain. The patient is started on heparin, but by day 5, the platelets are noted to have fallen to 80. A HIT test, PF4 antibody test is sent. What is the next appropriate step? A, continue heparin pending the results of this HIT test. B, switch to a low molecular weight heparin pending the results. C, discontinue heparin and begin anticoagulation with a direct thrombin inhibitor. And D, discontinue heparin and begin warfarin. The answer is to stop the heparin and start a DTI, direct thrombin inhibitor. That's argatroban or bivalirudin. So with HIT, the platelets are often falling, and we use what's called a 4T score to assess the pre-test probability of somebody having HIT. When that 4T score is elevated, then we assume that they have HIT pending the test results. And critically, we act on it. We don't wait because we don't want blood clots to form. And these blood clots are arterial or venous. So if platelets are falling, it's important to consider this diagnosis. And it does happen more with heparin than low molecular weight heparin, but it can happen with either. So switching to a low molecular weight heparin, once the diagnosis is being considered, is really too late. You have to switch to a direct thrombin inhibitor. The 4Ts, we think about the timing, the degree of thrombocytopenia, whether or not there are other clots, and whether or not there are blood clots, and whether or not there are other causes. So stop all heparin, and I emphasize all because it has been known to continue the process of HIT and thrombosis, even from heparin flushes in peripheral IVs, and then start a direct thrombin inhibitor. Starting heparin would be wrong because when HIT is active, heparin can lead to skin necrosis. So when a patient is on warfarin, we have to reverse it with vitamin K, and we can't restart the warfarin until the platelets have normalized. When there are blood clots present, we treat as a normal blood clot 3 to 6 months. And when there is no blood clot, we have to recognize that the clotting risk does stay for some time. It's not entirely clear how long to treat, but the clotting risk does seem to be elevated for another 4 to 6 weeks. So anticoagulating for that duration, I think, is important. I won't go through this slide in too much detail, but it just showing the mechanism of what's happening with HIT, where there's activation of platelets through these PF4 antibodies, and as well as endothelial activation or damage, leading to both the clotting risk in arteries and veins. Next question is a 28-year-old woman seen for preconception counseling. She had bleeding after wisdom teeth extraction in the past, but takes no medication now. Her family history is significant because her mother had a bleed after childbirth and needed to have a blood transfusion. Her sister also has had some bleeding problems. What's the next appropriate evaluation? A, thrombin time and reptilase time. Von Willebrand panel. C is factor 13 screening, D, euglobulin clot lysis time, and E, factor 11 activity level. The answer is a von Willebrand panel. Von Willebrand disease being the most common type of bleeding disorder. The panel includes both the antigen and activity of von Willebrand factor, the activity test being called ristocetin cofactor. And it also includes a factor 8 activity because von Willebrand factor stabilizes factor 8. And when it is not working or when it is low, factor 8 also becomes low. It is worth noting that people with blood type O have lower levels of von Willebrand factor by about 25%, yet this does not increase their risk of bleeding. The von Willebrand factor forms multimers combining with itself. These multimers are quite large, facilitating binding of platelets and collagen and forming clots, hemostasis. So it's so von Willebrand factor is helping bind to areas of endothelial damage and adding in platelets. And as I mentioned, it helps to stabilize factor VIII. We generally think of three subtypes of von Willebrand factor. Type 1 is a quantitative deficiency, type 2 is a qualitative deficiency, and type 3 is no von Willebrand factor. It's the most severe form. And then there are subtypes of type 2. Type 2N, I think, being very interesting because the mutation in the von Willebrand factor gene is the area that is binding factor, von Willebrand factor to factor VIII, where, it stabilizes factor VIII, but in type 2N, it's not able to do that. So these are patients that look like hemophilia A patients because their factor VIII levels are so low. The next question is a 67-year-old man with a history of hypertension and has a ruddy complexion and a systolic flow murmur. The CBC is notable for a hematocrit of 58%, white cells 9.8, so a little bit up there, and platelets 430. The serum EPO level is low. Which of the following is the next step? A, serum iron with an HFE gene mutation analysis. B, JAK2 testing. C, a sleep study. D, hemoglobin electrophoresis with P50 dissociation curve. The answer is a JAK2 test. One of the key features here, besides recognizing erythrocytosis and thinking about causes of erythrocytosis, is the serum EPO level being low. So it's trying to stop red cell production, suggesting a primary problem, not a secondary erythrocytosis. And that primary problem we call polycythemia vera. Most of these cases are caused by a JAK2 mutation, almost all, the typical one being the V617F, but there are other mutations in JAK2 that can cause this as well, making up for the others. Hypoxia is a common cause for secondary erythrocytosis. If your kidneys are detecting low oxygen levels, they make more EPO to make more red cells to compensate for that hypoxia. In that situation, we should be seeing an elevated EPO level, not a low EPO level. The next question is a 28-year-old man with no medical history, coming in with worsening fatigue and dark urine. His heart rate is elevated at 130. He's tachypnic, 24 rests per minute, and jaundiced. The white cells 9.8, hematocrit 12%, platelets 430, MCV 106. The peripheral blood smear shows numerous spherocytes, and the Coombs, the direct Coombs, is positive for IgG. The patient's antibody screen is reactive to all cells tested. The blood bank says that it may be 4 to 6 hours before a fully compatible cross-match unit is available. In addition to supportive care, with the folic acid and initiation of steroids, which of the following is the next appropriate step? A, transfusion of emergency release AB negative red cell units until fully cross-matched compatible red cell units are available. B, transfusion with the least incompatible type specific red cell units. C, observation until fully compatible red cells are available, or D, red cell exchange. So several key features here. One, we have a positive Coombs, the confirmatory test for autoimmune hemolytic anemia. The Coombs was IgG positive, which is more consistent with a warm autoimmune hemolytic anemia. And just going back to the data, we see profound anemia. The hematocrit of 12% is life-threatening. And the key here is that it cannot wait. It cannot wait for a workup. It cannot wait for the blood bank to get the perfect unit. This is somebody who has life-threatening anemia and must be transfused promptly. Now, the problem with that is the autoantibody that is destroying the red cells is causing the cross-matching process to be more difficult, since the autoantibodies are pan sensitive, and that's why it takes the blood bank extra time to get the cross type, the blood type correct. In that situation, we have to get on the phone and talk to the blood bank and say, this is a patient who cannot wait. Send me what you think is the best cross match. So the least incompatible or most compatible unit. And then, of course, transfuse, steroids, supportive care, and how, if steroids are not helping, how else can we stop an autoimmune process? Rituximab. Thank you.